Good afternoon, everybody. Respected chairperson, respected judges, my dear teachers, to our colleagues. Submacular blood removal with isolated autologous RP choroid patch graft transplantation in marked submacular hematoma. None of us have any financial interest regarding this subject. We know the causes of subretinal hemorrhage is AMD, PCV, macroaneurysms, or trauma. Usual prognosis of submacular hemorrhage is very poor due to barrier and toxic effect of the blood, as well as the shearing effect of the outer segment of the photoreceptor, and window of opportunity is within first 2 weeks of onset. And although the subretinal tissue plasminogen activator has some role, but for the large and elevated lesion for more than 1 month duration, vitrectomy along with subretinal blood removal without full thickness RP choroid graft transplant is an option. Our purpose of the study was to study the result of submacular blood removal with isolated autologous full thickness RP choroid graft transplantation in marked submacular hematoma cases. It was a non-randomized prospective study done in 8 patients of massive submacular hematoma from April 2015 to March 2017. And the surgical techniques, like in all 23 gauge vitrectomy done, followed by induction of retinal detachment like this with the help of 39 gauge or 41 gauge needle, and then creating a localized retinal detachment in multiple areas, injecting BSS, and then creating temporal 6 to 7 clock hours retinectomy. But where the retina is already elevated, like in this case of hemorrhagic retinal detachment, we did cautery, temporal cautery, 6 to 7 clock hours, and did retinectomy to gain access to the subretinal space. Now we have to remove the blood, so we are removing the blood from the subretinal space. Sometimes this blood is very much thick, and sometimes fibrotic scars are there, so you have to remove the scars by neovascular membrane also. Sometimes this neovascular tissue is very much fleshy. With the help of this ILM forceps, we are removing this submacular neovascular tissue. You should take the, considering the its surrounding retinal attachment, they remove the subretinal tissue, and subretinal blood has to be removed, and if there is some kind of oozing from the feeder vessel, you have to do mild cautery. Now, you have to inject PFCL subretinally to keep the retina apart, and do the you have to go for the RP choroid patch graft transplantation, taking the from the mid peripheral relatively healthy looking RP's areas, and taking the graft, considering its upside down manners. You have to reoppose it under the PFCL, and you have to reoppose it in the proposed site of fovea, and graft realignment done. They remove PFCL and then inject PFCL again over the retina to reoppose it, do fluid exchange, and silicon and PFCL exchange done. Postoperatively, we did wide field fundus photograph opto, serial OCT, ICG, and multifocal ERG done. We included post-AMD, post-PCV marked submacular hematomas, excluding small and medium-sized submacular hematomas, submacular hematomas of other origin. These are the clinical characteristics. Complications noted: recurrent retinal detachment in first case, and excessive subretinal scarring in fourth case. Like mean age of presentation was 67 plus minus standard deviation in years, and mean post of VCBA improved to 1.17 plus minus standard deviation in logMAR. Graft anemia decreased with follow-up, and like in this case of submacular hematoma post-AMD, visual improvement seen from PLPR to logMAR 1 after 3 months, and you can see the submacular graft in situ after 15 months of the follow-up. You can see gradual decrease in graft edema. This is a case of CREST 2 submacular hematoma with for post-AMD, visual improvement seen from PLPR to logMAR 1 after silicon removal. You can see the autologous RP graft, 9 months follow-up, and you can see the graft in situ, gradual decrease in graft and graft edema, and ultimately graft has been incorporated into RCC complex. And case 3, submacular hematoma AMD, where you can see visual improvement seen from hand movement to logMAR 0.78. Post AMD submacular hematoma, post SOR, you can see the submacular graft in situ, but there is excessive scarring. Another case, post AMD, post PCB hemorrhagic retinal detachment, visual improvement seen from PR inaccurate to logMAR 1.4. Another case of post PCB visual improvement seen from finger counting close to face to logMAR 1 after 6 weeks. Another case of hemorrhagic detachment, visual improvement seen from PR inaccurate stage to logMAR 1.4. Post AMD submacular hematoma, visual improvement seen from hand movement to logMAR 1.4. So multifocal ERG showed some waveform in all, some waveform in comparison to the other eye. ICG showed revascularization of the translocated graft in 2 months, And like this is the first study in India, and like other studies, in our study also showed that a submacular blood removal with full thickness RP choroid graft is a viable option in cases of severe vision loss. Beneficial effect of submacular blood removal, it removes the barrier toxic effect of the submacular blood, as well as removal of the CNB tissue nearly completely remove the possibility of the rebleed. Beneficial effect of autologous RP choroid patch graft, it provides healthy RP cells, as well as the development of new feeder vessels on ICG denotes that revascularization in ICG is anatomical viability, and post-visible ERG means it is functional improvement. So timely drainage is essential, and removal of the neovascular tissue is almost remove the possibility of the rebleed and decrease the cost burden of the intravitreal injection. Autologous full thickness RP choroid transplantation provide healthy RP cells, and ICG ERG proved both anatomic and functional improvement, as well as restoration of anatomical ambulatory vision with minimal risk recurrence. So we can conclude, we can give something almost in no hope situation to some hope. Thank you.
Inclusion criteria.
Yes.
Mentioned as marked
Submacular
submacular hemorrhage. Is there any definition which you have included? Like, is it number of disc areas, or based on the OCT submacular bleed thickness,
No,
or is there any criteria for that?
I have already mentioned it is more than 5D diameter in the fundus photography, in the not in the OCT guide. It is a fundus photography. It is a hard mark, and mostly it is if it is much elevated lesion. For those cases, initially what happened before starting this study, we have injected subretinal TPA, vitrectomy, and subretinal TPA. But in those cases where there is huge hemorrhagic detachment, or like huge elevated marked submacular hematoma, these cases usually fails. And usually when we are removing this subretinal blood, we are removing the subretinal neovascular tissue along with the scar tissue also.
So you are not tried vitrectomy displacement with TPA directly?
No, vitrectomy with submacular blood removal.
Yeah, no, you haven't attempted any cases displacement.
Displacement I have tried previously, but displacement works in case of moderate kind of less than 5D diameter, small submacular hematoma. These cases doing very well.
Is there a time cutoff for inclusion into this?
Yes, more than 1 month duration. It is. I am much more included.
Mentioned it in your inclusion or exclusion criteria.
Yes, it is those cases also.
Okay, thank you, Dr. Shubhendu. And with this, we'd like to call next speaker, Dr. Nishikant Borse.
Can I present my next paper also? I have 2 papers. If you
I have no objection.
Any objection? Okay. So we'll go on the next work of Dr. Shubhendu for on new vitreoretinal challenges eye with permanent keratoprosthesis.